Yeah. Good evening, all. Welcome back again to the Cycle 2 module of Antimicrobial Stewardship that is organized by FCPI. Today, we are going to discuss about intraventricular and intralumbar antimicrobial administration. And the speaker would be Dr. Shaili Gori. And she is like working as an ID pharmacist at PD Hinduja Hospital, Mumbai. And ma'am has almost 8 years of experience in this domain, and also ma'am is an SIDP AMS pharmacist, and she had SIDP certification. And now currently ma'am is working as an ID pharmacist, and also she is undertaking few projects that was funded by ICMR, Pfizer, and also NARI. So she is well expertised in clinical pharmacy aspects related to infectious diseases, antimicrobial stewardship. So without any delay, I would like to hand over the platform to Dr. Shaili Gore. So the session is yours, ma'am. Please.
Satya, for the introduction. I just want to welcome everybody again for my topic from FCPI, and good evening, everybody. So today we'll explore the intrathecal route of antimicrobial administration. Intrathecal route is basically a generic term, but which which has two particular routes such as intraventricular and intralumbar. So these are the two routes that we will dive into, and I'm just going to cover the administration part of it and little bit of PKPD and some important aspects that you should keep in mind while you're into practice. So there are some nosocomial CNS infections such as nosocomial meningitis, nosocomial ventriculitis, postoperative or healthcare device associated neuroinfections, or even neurodevice associated shunt infections, which carry serious morbidity and mortality. And they, because of inadequate or delayed intravenous therapy, these infections may need antimicrobial installation. And usually, this direct installation in the brain or the spinal cord is always used as a last option. So, globally, there are the CNS infections, particularly meningitis, ranges from 1 to 7%, depending on the population type, the healthcare setting. It is very, very common in the neonatal population. And post-operative meningitis have been observed between 0.3, very minimal, to 25% overall. But the data is very scarce, specifically from the Indian settings. And as I just mentioned, that whenever the IV therapy in these cases is very challenging due to the limited penetration of drugs, usually there are many antibiotics that do not penetrate easily through in the central nervous system if you are given IV. Therefore, we use this direct antibiotic installation through these two routes, that is intraventricular and intralumbar routes. So the benefits of these routes have actually outweighed the risk in special circumstances. Although this is a 60-year-old technique, it is a widely emerging route of administration, but there is very limited evidence and limited practices or limited data that is coming out. But it is a very interesting route for us to focus on, because there are a lot of PKPD aspect also, and as well as administration aspects which are very associated with these routes. So this is a reference image that I've just put up for a simple explanation about the central nervous system, a human central nervous system. It consists of brain, spinal cord, venous sinus, subarachnoid space, arachnoid granulation, ventricles, and choroid plexus. Uh, these two parts are the main parts where the CSF is present or produced, and where the drug is administered. Then other parts are cerebellum and some foramen, where the CSF keeps on circulating between the brain and the spinal cord, like it is always getting distributed. to and fro between the brain and the spinal cord. So first, and most importantly, let's understand the CSF physiology and little bit of structure briefly, because we need to understand this only. Why? Because we need to understand where the drug is being actually instilled and how it is distributed and how it is, effectively, I mean, utilized for killing the bacteria that has been there in the brain or even the spinal cord. So Edin Swedenborg was a Swedish scientist in the 18th century who wrote a lot about brain and the nervous system. And during his research about the central nervous system, he termed it as the seat of the soul. He discovered a central cerebrospinal fluid. He named it as seat of the soul only because he found that this CSF were the central that were linked to the life and consciousness of the living being. And it was only other scientists such as Harvey Cushing and even Alexander Monroe that termed its dynamics. That is, they summarized the production, circulation, and clearance of the CSF, and they termed it as third circulation after the systemic and the pulmonary circulation. So CSF is nothing but a mixture of sodium and bicarbonate ions. It is acidic pH, and it also this sodium and bicarbonate ions attracts the water through the osmotic gradient, and it is produced by the choroid plexus. You can see over here, and usually this is produced only in the third, fourth, and lateral ventricle. So what happens is the incoming. So this is a heart. The incoming blood from the arterial capillary, the main artery that connects to uh, the choroid plexus. Here it you can I hope you can see the mouse where I'm cir circling the mouse. So there is a choroid plexus that is connected to the blood artery, and the CSF is produced from the blood components, but the entire blood is not entering it is getting filtered, and only the sodium and the bicarbonate ion and the water is getting attracted, and the CSF is produced in the choroid plexus. Then there is another blood vessels that actually irrigates the CNS lining, that is the blood capillaries that are usually surrounded with these astrocytes and pericytes. These are the ones that help in circulation of the CSF within the brain and the spinal cord. And then it keeps getting reabsorbed, distributed, and keeps getting produced, distribute, and keeps getting reabsorbed. Then CSF flows usually through the four ventricles, which we have seen in this picture. There is ventricles over here. Gets produced over there by the choroid plexus. It flows through the ventricles. It goes into the aqueduct, then the further basal cisterns, cerebral convexities, the subarachnoid space. It goes to the spinal cord and then goes back. And this flow is influenced by the size, the ventricle size, the CSS space, the age, posture, how we are sitting. I mean, the patient is lying or whether he is in a supine position. Then the pulse rate and the respiration rate, which is actually also the key for the drug circulation. So the movement of the CSF mainly driven by the respiration and the pulse. The heartbeat and the respiration oscillates the CSF. So this circulation is very important to understand because the drug circulation goes along with the CSF. Therefore, I have put in the explanation of CSF. And usually, by studies have shown that the adult CSF volume is around 150 to 250, but there are studies that are showing more CSF, such as 326 ml. Then the children are having less CSF volumes. Therefore, the doses are very less in them. Then if there is any hydrocephalus present, if it is communicating, then the CSF is enhanced, the CSF production is enhanced, it becomes 488 ml. And if it is non-communicating CSF, it is 593 ml. So basically the function of the CSF is just to cushion our CNS system and to deliver the nutrients for the proper functioning. Then So, so I just explained about the flow of the CSF through choroid plexus as well as the blood capillaries. So why I explained these two parameters is because not everything goes into the brain. As you all know, we all study in our human anatomy and physiology that there is something called blood-brain barrier and blood CSF barrier. So what the blood-brain barrier, which is this is the picture. The second part is the picture of a blood-brain barrier, just at a cellular level. So what it consists of, you all know that any barrier in the body is consists of endothelial lining, but in the brain it is a very tight junction of the endothelial lining, and the blood-brain barrier composes of the astrocytes and pericytes that forms the barrier between it separates the blood from the interstitial fluid and the spaces of the brain. And there is a blood CSF barrier. It separates the blood as well as the choroid plexus and the arachnoid. The arachnoid and the choroid plexus barrier separates the blood from the CSF. So there are two barriers. One is CSF and blood barrier, and one is blood and the interstitial space barrier. So these two are important to understand because no antibiotics, there are very, very, very few antibiotics that penetrates in these two barriers, and they are all dependent on the molecular size. We'll go into it ahead. So these barriers usually are the, as I just mentioned, they're the lipid layer composed of endothelial cell and are very, very tight junctions in the brain, and which are surrounded by pinocytes, astrocytes, choroid plexus, subarachnoid space, everything. And there are many, many, 1 is to 5,000 capillaries that are protecting this barriers. And PBB and BCSFB, that is, these barriers are nothing but just a protective mechanism from brain from uh, any, any endogenous substances or exogenous compounds or blood waste or even trauma for that matter. But there is one important thing that any infection or inflammation disrupts this mechanism, and therefore it facilitates entry of pathogens or anything in the brain, and that's how you get the infection. But there is something called steroids that reduces the inflammation and reduces the entry of the substances that also may reduce the entry of the antibiotics or antimicrobials. Therefore, there are separate guidelines of when to begin steroids in cases of meningitis or when not to. So that is another topic. I'll not go deep into it. So how a bug and a drug is transported into the CSF? It's very simple. Bug invasion occurs through the transcellular and paracellular and infected phagocytic routes. But the drug penetration depends on the serum. It occurs by four mechanisms. One is suppose the drug is given IV, it will cross the barriers. It will move via the CSF bulk flow. Three mechanisms: CSF bulk flow, a retrograde diffusion, that is the passive diffusion, and active transport. Retrograde diffusion is the main transport system of the drug, and then it diffuses mainly into the extracellular with or without intracellular. So there are very few antimicrobials that are going into the intracellular spaces, and because of this limited antibiotics available, that's the reason we are giving the antimicrobials through the direct instillation into the brain. And the drug penetration also depends on the serum levels, uh, the serum to CSF ratio, the inflammation, the antibiotic properties, protein binding, lipophilicity of the drug, molecular mass, clearance, and CSF production, and the rate of distribution. So this is just a image that is actually showing there are some methods or materials that has been strategized for the blood-brain barrier regulation and the brain-targeted drug delivery. So till now, I'm just telling you about the when the drug is being transported by via the IV route. So there are some pathways like transporter-mediated pathways, receptor-mediated pathways, cell-mediated lipophilic pathways, efflux pump, absorptive and paracellular aqueous pathways. So these are the pathways how the drug is being transported. We already studied what the how the BBB and the blood structure and the CSF structure was. But because of these very protective barriers and very inhibited transport, there are some uh, engineered materials for the brain targeted delivery that has been developed. One is administration. Then there are some formulations that come with liposomal or polymeric materials that are easily going into the brain. Then there are some other very invasive or external methods like disruption of the brain barrier. But they are very, very high-fi, and let's not go much into that detail. But there is a very slightly invasive strategy that has been developed, which is our intrathecal route. So intrathecal route consists of intraventricular and intralumbar route. So you can see the first picture is about the intralumbar drug delivery, which I will call it as intrathecal drug delivery. It is given into the spinal cord, into the subarachnoid space. There is some implantable pump that is fitted with a reservoir, and then the drug is given through that. But it is very rarely used, especially it is used for chemotherapy. So more antimicrobials or antibiotics are given by intraventricular route. The second picture is of the intraventricular drug delivery, where there is an implantable reservoir that has been placed under the just under the scalp, and there is a catheter and a which is instilled into directly into the ventricles, where I just mentioned in my first few slides, where the ventricle and the the choroid plexus is present. It is producing the CSF. The drug route is, I mean, the reservoir is just implanted into directly into the that space where the CSF is produced. So this is a little bit of enlarged image where the catheter is getting, it is going through everything, like the scalp, the brain, and the CSF, and even everything, whatever the brain structure is made of, it is directly going into the ventricles. So because there is a direct instilled catheter where the CSF is produced, that's how the antimicrobials are going through this catheter and they are getting circulated through the process that I just explained before. So just remember that whenever you go on rounds and if you see any potential patients for intraventricular therapy or the intralumbar therapy, then just remember that any by hook or crook or by any circumstances, by any chance, you don't have to send the culture after starting the therapy. It will just make everything go in vain. So please make sure that from AMSP point of view, that you make sure you are encouraging the doctors or the sisters to send the culture prior to starting this therapy in all, even prior to giving any steroid therapy as well. So there are two routes. One is intraventricular and one is intrathecal. So for intrathecal, the patient is lying. For the intraventricular injection, the patient is positioned in either a supine position or in a semi-flower position, like he is slightly elevated, or he's either put he's lied down completely. For intrathecal lumbar administration, the patient is positioned in a side-lying lateral decubitus manner. This is usually done just for the ease of administration and even for the extraction of CSF. So what's the neurologist? So this is not done by sisters at all. This is not done by any intensivist or any doctor. Only and only the neurologist is licensed or allowed to do this intrathecal route of drug administration. Some oncologists are doing it, but they're only doing it intrathecal, they're not doing intraventricular. So focusing on the intraventricular therapy, the neurologists are the ones who are actually administering via these routes. But we are the ones, ID or the intensivist or ID pharmacists are the ones who decide the dose and the further process that I'll be explaining to you. So once the cultures are obtained, then you start the patient for this administering this therapy. So what the neurologist will do is he will extract some amount of CSF just to account the dead space for the proximal catheter, so that the drug is not just remained in that catheter, it will go inside. That's the reason you will take the CSF, little bit of CSF uh, 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 outside, then you will give the drug. And usually the administration volumes of the drug are very small. They're just between 5 to 10 ml. You can't give 20 ml, 30 ml. You have to make sure that the volumes of the drug administration are very small, like 5 or 10 ml. And then administered through EVD, that is the ventricular drain and Omaha reservoirs or the shunt. But the current evidence, by the current evidence, it is not clear which volume of antimicrobial should be diluted and at what concentration. But by any studies or even the IDSA intraventricular guidelines, if you will see, they are all suggesting that the least minimal concentrations you have to, volume and the concentration you have to administer. So the smaller doses are pushed over 15 to 20 minutes. And after the administration, it is then, I mean, you're again advised to rinse the catheter or flush the catheter with either water for injection, the bacteriostatic water for injection, or 0.9% sodium chloride. But again, there is unclear evidence for this. And after administering, there is a ventricular drain that needs to be clamped for at least 15 to 20 minutes so that the drug through the CSF is equilibrated. So, sorry, I have not put an image of the EVD and the how it has been clamped, but there is an apparatus of EVD. I think I have in my further slides. So there is an apparatus of EVD. You give the drug and you clamp the CSF. I mean, you clamp the catheter so that the drug that is being instilled through the catheter doesn't come out of the uh, Omaha reservoir shunt catheter. So it is advised to clamp just so that the drug is completely flowing through the CSF. There is a slower elimination and increased half-life. But some drugs have been clamped. Intervals up to 6 hours have been reported. And intralumbar, another route, that is intralumbar route, it is just easy. You just doctors are just putting it into the spine and they're administering. But again, I'm telling that intralumbar routes is usually uh, suggested only for chemotherapy, not antimicrobials. If there is any spinal infections, then that comes under osteo management. So there are many drugs that enters the bone and the spine. So you don't really need to give intralumbar antimicrobials. Then even if they are giving, intralumbar requires prone position to increase the ventricular concentration as well. If any infection is in the lumbar, it will definitely the brain also will be targeted. That is also one reason why intraventricular routes are uh, preferred than the intralumbar. So what formulation is used? Sterile form, any antimicrobial which is very sterile, which is free of preservatives, pyrogens or pyogens, endotoxins, particle contaminants or coloring agents. And the ones that are allowed to be reconstituted in 0.9% NS or water for injections, then I just mentioned smaller volumes are required with suitable pH of 7.3, that is matching with the CSF pH, and osmolality of 281 milliosmoles per kg, that is again matching with the CSF. And along with this, the intracranial pressure as well. And epileptogenic potential drugs or even excipients in the formulations are contraindicated. So as a pharmacist, you need to, I'm telling you that no doctors will have time or they won't have cognizance to see through the formulation what is included in the as an excipient, whether it is epileptogenic or not, what is the pH, what is the osmolality of this formulation, whether it is pyrogen free or not, whether there are particles or not. Every brand also has variations are there in every brand. So every brand can come with some different kinds of formulation. So you don't have to give, uh, for example, there is one anti like there is one drug that is amphotericin B. So it comes with two formulations. One is liposomal and one is conventional. So while giving that formulation, you have to make sure that there is no conventional formulation gone. You have Advisable formulations are liposomal amphotericin B formulations for the intraventricular routes. And the indications for this route is uh, they are indicated only for nosocomial, not community acquired, but only indicated for nosocomial, especially post-operative neurosurgical infections, that is meningitis or ventriculitis. If they are having multi-drug resistant bugs, they are not at all indicated empirical, and they're always chosen as a last option, especially because the removal of the devices, that is when the patients are coming with stroke or any intracranial hemorrhage, the EVD or the VP shunts are placed in them. So these devices are associated with most commonly associated with these kinds of infections. So you are supposed to give, if you give the antimicrobials to the intraventricular route, it is easily because it is easily, the concentrations are achieved very easily, and they bypass the systemic circulation. So, when the removal of these devices is risky or it is not advisable, then these therapies are indicated. Then, if the systemic therapy, that is the IV therapy alone, or if the drug of choice fails to enter the blood-brain barrier, or there is a therapeutic failure upon repeated administration of higher doses that has been indicated by intravenous routes, if the antimicrobial sizes are molecular size is very large, or if they are very toxic when they are given systematically, then also you can give those therapy by the intraventricular routes. And common pathogens targeted for these routes are uh, coagulase negative Staphylococcus, Staph aureus, Acinetobacter, Klebsiella E. coli, Pseudomonas. There are many Acinetobacter patients that, meningitis, nosocomial post-operative. Again, I'm mentioning post-operative neurosurgical infections. The ones who have devices, that is EVD or VP shunt in the brain that has been implanted. Staph aureus and Acinetobacter are very common in them, and even Klebsiella and Pseudomonas. So, I just mentioned that intraventricular therapy is better than intralumbar, as the CSF distribution with the intraventricular therapy is higher than intralumbar, and they attain the ventricular concentration very rapidly. Uh, yeah, so if these therapies are combined with the systemic therapy, they will achieve the inhibitory concentration, reduce relapse, and prevent resistance. So it doesn't mean that if you're giving the interventricular therapy alone, you don't need to give IV therapy. You have to give the IV therapy so that there is no sub-inhibitory concentration even in the blood as well. Like you need some concentration in the blood so that it will support some distribution in the brain. And the dose-related toxicities by the intraventricular are expected, but they can be overlooked if the patients are very sick. Like the doses given in intraventricular are, as I told you, they're very in small amounts, but the doses are also very small. It's like if you're giving five, you're supposed to give 5 mg of colistin, and I mean that is even the higher dose that is used, uh, just like IV therapy. So even if there are some toxicities expected with this, they can be overlooked because the patients are very sick, and they have recurrent meningitis or they have relapse. So what are the advantages or limitations with these therapies? The advantages of these routes are very homogeneous. Uh, the distribution is very homogeneous throughout the space. The Ommaya reservoirs that are being implanted for the administration are generally safe. They are not very complex, but they're safe, and it attains a very quick sterilization of the CSF, and especially it bypasses the systemic circulation barriers that we just discussed some time back. Then there are many limitations, or particularly only one limitation of this intraventricular therapy is chemical meningitis. It is very, very common, chemical meningitis or arachnoiditis, which is followed by the pleocytosis. And there are some studies that are saying that dexamethasone is to be administered before the intraventricular therapy just to avoid chemical meningitis. But then again, there is no much data to prove this. And there are some other risks such as improper catheter placement, toxicity or infection, or a secondary infection, another infection can come through it. Accidental overdose can happen by instilling the antimicrobials directly. Hemorrhage or malposition can occur, or if there is any obstruction. And even leukoencephalopathy is also one limitation with this therapy. So what are the pharmacokinetic factors? I'll quickly take through this. Usually the pharmacokinetics, there are very few studies that have described the pharmacokinetic despite a variety of therapeutic agents. So there are some lipophilic antibiotics like rifampicin, amphotericin B, metronidazole, or sorry, not amphotericin B, rifampicin, metronidazole, or fluoroquinolone that are lipophilic. So lipophilic antibiotics are the antibiotics that actually penetrates the blood-brain barrier, and they have rapid entry, and they are not at all affected by the inflammation. But there are some other antimicrobials such as vancomycin or beta-lactams. Their transport only depends on the opening of the tight junctions. Like if there is an opening of the tight junctions of the endothelial lining, then there are some penetration of vancomycin or beta lactam. That's why you must have seen that in patients with meningitis, beta lactam such as meropenem are still prescribed but with higher doses. So that the higher doses, if there is an opening of the tight junctions because of the meningitis inflammation, there can be some drug transport through the tight junction, even though they have very limited CSF penetration. So the high doses can suffice for it. And then there are some other antibiotics such as ceftriaxone and teicoplanin that have high protein binding and which has delayed entry in CSF. Any drug with higher protein binding has delayed entry into CSF. Other drugs which have very, very high molecular weight such as vancomycin have inhibited entry of the drug. Then the drugs that actually transport through active transport like cephalosporin or penicillin, they are actually transporting through active transport, and they have this transporter proteins like OET. OET are the transporter proteins that inhibit. They also transport the drug into the CSF, but they also have a elimination property. Like this OET transporter protein, they also remove the drug. Then another factor is meningeal inflammation. It inhibits the elimination pump, and there is an increasing penetration of these drugs, uh, decrease in penetration of the drug when the steroid is given. So when the steroid is given, the inflammation is reduced, and thereby it will decrease the penetration of few drugs that is actually going inside because of the inflammation. So overall, you have to design the regimen with sound PK properties, and the ADME depends on the low molecular weight, low ionization, physiological pH, high lipophilicity, low protein binding for a drug that penetrates to CSF, and also the clearance from the CSF. Other factors are age, size of CSF, the subarachnoid space, the ventricles, and the spinal cord dimensions, the CSF volume and the production rate, the distribution, abscess, and even some other diseases like neoplasm or lesion, blood clots, hemorrhage that will also alter the PKPD of the drug because it will block the CSF flow and distribution. Hence, the drug flow is also blocked. So the dose interval also depends on the CSF volume and the drain. So the OD in general, the once daily dosing is recommended if the drain is more than 100 ml. Alternate day dosing is recommended if the EVD drain is between 50 to 100 ml. And every third day, the dose interval is recommended if the drain is less than 50 ml. So I'll just take to a okay. So there are some, like I just mentioned, whatever is there in the slide. I'll come to the doses in the further slides, but the dosing interval is dependent on the ventricular drain that has been occurred. And any infection or inflammation in the brain, it enhances the CSF production. So when the CSF production is enhanced, there is no space for the brain to keep it. So if there is lot of CSF in the brain, it will create high intracranial pressure and which will lead to further complications. So therefore, the drains are fitted in the patients with through the there are some drains, EVD drains are fitted to drain out the CSF mechanically. So there is a mechanical drainage that is happening so that it drains out the extra CSF that is being produced in conditions like meningitis. But what happens is the antimicrobials are also getting drained with it. So because the antimicrobials are getting drained with it, the dosing and the intervals of the antimicrobials are dependent on the rate of the CSF, extra CSF produced, and even the rate of the drainage. So here it is mentioned, the same thing that I just told, it is mentioned over here. But I'll take you through a case. There was a patient, 45-year-old female with meningitis. She had post-operative neurosurgical infection and meningitis. And she was advised as intraventricular colistin as 5 mg BD. That is 10 mg per day. So the doctors asked us that can we exceed the dose from 10 mg of colistin. So we did find some literature where there are some 20 or 30 mg of colistin used, but it was just one case report. But we can't compromise the patient with lack of evidence, so we did not suggest high dose. But what we suggested is that we first saw that the intraventricular administration by the neurologist was given just in 5 seconds. Like usually the administration of intraventricular therapy is supposed to be slow push, but that slow push is supposed to be over 10 to 15 minutes, maximum 20 minutes, and not bolus. And the initial EVD clamp time was only 30 minutes. Like the drug was given, the clamp time was done only for 30 minutes, and the patient's CSF drain was around 250 to 300 ml. Extra. This was extra CSF drain, which was 250 to 300 ml. So we also have an article of colistin where the pharmacokinetics is altered if the drain volume is high. So there is one, they even showed the relationship where more the CSF is produced, more it is drained, and more the uh, clearance of colistin occurs. This will lead to therapeutic failure, and this will also lead to achieving lesser th- uh, concentration in the CSF for the bacterial killing. So what we suggested to them is that you, instead of giving the bolus dose of intraventricular therapy, you can uh, give the dose through slow push so that it is completely administered. The drug does not remain in the dead space of the catheter. Administer the dose over 10 to 30 minutes and clamp the EVD for 4 hours and then drain the CSF. I'm sorry, I didn't put the picture of the EVD and the Omaya. I think I have in some other another slide that I'll show you sometime later. But what we did is we told them to clamp the EVD for 4 hours after giving the drug, and we let the drug equilibrate, and the clamp EVD was then released, and then the CSF was drained after 4 hours. So this made the drug remain in the circulation, the brain, and get distributed equally. And we had this. I mean, the patient was cured at the outcome of this patient that was that she was cured at the end of the therapy. So we gave this intraventricular therapy at least for I think 4 to 5 days. But she also had IV therapy ongoing for additional benefit. So there are some PD factors that are a focus, that is CSF to MIC is the most common PD factor that is being targeted. However, we have very limited data, but there is some recent data which is coming, which is most reliable is on AUC CSF to AUC plasma. That is how much ever dose you're giving through the plasma. The always there is X percentage of uh, the drug is getting distributed through the CSF from the plasma. But again, this is about the IV therapy. So what in when the drug is given intraventricular, there is a PD strategy that is adopted to maintain the peak concentration in CSF. but above MBC, that is a minimum bactericidal concentration, which is usually 10 to 20 times higher than the MIC. So you know that every antimicrobial has a different PD target, that is time to MIC, Cmax to MIC, or AUC to MIC. When there is IV therapy given, then these parameters are coming in the picture. But when there is intraventricular therapy given, then you have to make sure that the CSF to MBC concentration is usually should be higher. So the CSF to MBC concentration is the one that has been recommended. Then what are the eligible antimicrobials for the intraventricular and the intralumbar therapy is the antimicrobials that are not going through the blood-brain barrier, which are hydrophilic or they have high protein binding, and they're high in molecular weight and size. So there is an article that I have put a reference below. So I've just made this table for a better understanding about the different kinds of antimicrobials that are studied for the intraventricular therapy along with their doses, and adult doses and the pediatric doses are different, but there are many adverse effects also that have been accounted for with these kinds of antibiotics, but they can be overlooked because you need to treat that patient with the meningitis. So there are different adverse effects that are being given in that table. So, so this is the same table. I just made it easier for you all to understand. And not all antimicrobials are eligible for the intraventricular and the intrathecal therapy because there are some antibiotics like linezolid, metronidazole, rifampicin, azole antifungal, flucytosine, tetracycline, fluoroquinolones that readily pass the blood-brain and the blood CSF barrier, and they also have lower systemic toxicity. So they need not be given by these routes. Then there are some antimicrobials that are beta-lactams or cephalosporins. They have epileptic or myoclonic potential to cause epileptic or myoclonic seizures. They have potential to cause neurotoxicity. That's why they are also not, I mean, even with the little doses directly in the brain, they will cause this kind of neurotoxicity. So they're not advised to be given by intraventricular route. Although they don't pass the blood-brain barrier, but they're still not recurrence, difficult to treat pathogens. They also depend on the infected shunt or device. Sometimes it is not possible to remove the device, so the intraventricular therapy is suggested for a prolonged period of time. Then, for example, if it is uncomplicated meningitis, then you will just get away with 48 to 72 hours, especially with if the meningitis is due to coagulase negative staphylococci. And if the repeat culture is positive, there are some indications where you can give intraventricular therapy for 10 to 14 days. Uh, so whenever the drug is being administered in the CSF directly, the clearance rate is lesser and the half-life is very high. That's the reason we give only a very small dose and we give in very less frequency. So I think this is all about the intraventricular administration that we need to know as a clinical pharmacist. So I guess I've covered everything. And this is my last slide. So if there are any questions, you can always contact me or email to the FCPI so that we can answer your questions. And so this is it. I end my topic over here. I think I've covered all the topics, all the parameter or all the points that you need to remember as a clinical pharmacist. So I've not gone much into detail. I've just briefly covered the important points for you all to remember. And whatever the references that I have shown you throughout the topic, then you can just go through them and you can study about those articles. But I would like to show I think that slide got hidden by mistake. Uh, this was the same slide. This is the way, this is the Omaya reservoir, and the injection is given through this Omaya reservoir, which is directly into the ventricles. This is what I was talking about. So I think this is it. This is all from my side. If you have any questions, just like I said, you can email it. And a very happy new year to everybody. Thank you. Over to you, Satya. Are you there?
Yeah, yeah. Firstly, thank you for this wonderful presentation, ma'am. Generally, this is a topic where like there are limited literature and followed by the guidance is like very less. We
Yeah.
generally look, we have many questions when we deal with dosage adjustments, when it is like really dealing with clinical cases. So yeah,
Yes.
this is a like unique topic that you preferred and you just justified it. Uh, can I go into few queries which I noticed?
Yes, sure.
Yeah. First, coming to this administration part, ma'am, like you are mentioning whatever the antimicrobialities need to be administered like between 10 to 20 minutes. Is there
Yeah.
any concept in this like a kind of mm, like other than intermittent dosing, is there any prolonged concept in IV, I mean intraventricular or intrathecal concept, ma'am?
Um, So, by and large, all antibiotics that are recommended to be administered is all depend on the apparatus that has been instilled or implanted in the brain. I mean, there is
Okay.
just like I showed over here in my starting slide. This is the apparatus. So you can't administer the drug through this. This is a reservoir. There are many
Yes.
reservoirs, like usually commonly used is EVD and Omaya reservoir and VP shunt. VP
Uh,
shunt is very rarely used. VP shunt is used when the intracranial pressure is rising because of the hemorrhage and everything. And the VP shunt causes infection, and then the antimicrobial are going through the VP shunt. I don't have a picture of VP shunt, but it is similar. Like this is a Omaya reservoir. It's like a mushroom type device which is just instilled below the scalp. So it is very difficult to administer prolonged infusion through this route. I mean, this Omaya reservoir, because it is very sterile and we need to maintain very very aseptic environment, and only the neurologist along with the assistance of her sister is I mean advised to administer. So you have to completely open that sterile space which is actually covered with a green sheet, just like central line, and when the neurologist is administering, he opens everything and then administers. So it's practically not possible to give prolonged infusion or give the drug over 30 minutes or 1 hour. So all antibiotics in general are recommended to be administered through just by slow push, but over maximum is 10 minutes minimum, 30 minutes maximum, slow push. So I hope I answered your question rightly. Am I audible?
yeah, yeah, you are audible, ma'am. Just a small disturbance.
Okay.
Yeah, it's very clear. Like Omaya reservoir is something like we need to administer certain dose of drug and followed by it would be like controlled release. Is it such a kind
Yes,
of
yes.
concept, ma'am?
Yes, it has to be
Okay.
done under a very controlled process, and there is a there you need to follow, like I told, very small amount of doses that are here mentioned in this slide. So there is one
Okay.
article that has been actually telling us. This is the same article. There's a reference below. This article will tell about every drug, the dose and the interval of the intraventricular by the
Okay.
intraventricular.
Understood. Understood,
So
ma'am. Clear.
But I've seen only one article that has all the antibiotics together over here, which are
Yeah.
specific to intraventricular. And along with this, there is an IDSA guideline for healthcare associated ventriculitis. Even that has some studies quoted that are showing about the doses and the dose intervals. But commonly, the infusion rate is supposed to be only 10 to 30.
Okay. Okay. Noted. And there is one more concept when we are dealing with antibiotics and this inflammation part of meningitis. That is, if there is a doses regimen having corticosteroids like dexamethasone something, and
Yes,
followed by antimicrobials, uh, there are few literatures will be suggesting that first antibiotic need to be administered, then followed
yes,
by steroids. Is it like a proper practice, ma'am? Because this, if you give this corticosteroids, maybe the inflammation kind of condition would be coming down. So because this impacts that, like the penetration of antimicrobial to the infection site.
yes. So
So this is one more concept that we have generally
you
dealing with the doubt during our rounds.
Yeah, so I have mentioned about steroids somewhere, but I will talk about uh, so what you
Yeah, based
asked,
upon that.
it is about IV therapy. So
Yes.
your question is related to IV therapy, and when during meningitis there is inflammation, so they recommend to administer antibiotic before the steroids. Why? Because when the antibiotic is administered, because of the inflammation, there are some antibiotics that will get penetrated only and only because of the inflammation. But what
Yeah,
steroid
exactly.
does is, steroid will reduce the inflammation and which will restrict the passage of the antibiotic. This is the reason why they recommend steroid should be given after the antibiotic. Some
Okay.
infections are there, some pathogens are there that do not even need steroids. Steroids are indicated only for few meningitis, like I think streptococcus pneumonia and Haemophilus influenza. Only these two meningitis particularly require steroids. Others don't require steroid, but there's a lot of uh, I mean many studies are there which support or do not support the administration of steroids in meningitis, or even the timing of it is also being focused on. But when the drugs are given through intraventricular, then all this doesn't matter, that because the drug is directly going through the spaces and it is directly going into the ventricle. So inflammation or steroids don't matter in intraventricular therapy.
Okay. Clear. And when we come to these PK/PD parameters of an antibiotics, ma'am, I mean antimicrobials, is it like based upon volume of distribution, the dose and frequency will be adjusted?
So the frequency of intraventricular therapy is not adjusted based on the volume of distribution. It is adjusted based on the intracranial pressure as well as the drain that I just mentioned. I think
Okay.
this article has the frequency that as the more the CSF is being produced, the more there will be accumulation and the more there will be drainage, because you under normal circumstances CSF is getting reabsorbed on its own in people like us. But if there are patients who have a disrupted mechanism of the brain or the spinal cord, the CSF is a protective mechanism. It will create extra volumes or extra amount of CSF is produced, and for that there is EVD that has been placed just to drain the CSF volume. And because of the extra CSF, there is high intracranial pressure as well. So because of the high intracranial pressure, there are some other things also coming into picture. That's the reason why the frequency has been adjusted based on these two mainly. So the clinical pharmacist should keep in mind about the drainage and the intracranial pressure to adjust the interval. But for the dose, yes, it is dependent on many factors like the dose drug property itself. It is dependent on the ventricular size, the CSF production, the rate of CSF production, the age, and yeah, the in general the ventricular spaces and the intracranial spaces. So the dose is also dependent on that. So that's the reason I made two separate tables for adults and pediatrics. So in adults, there are uh, doses a little bit higher doses than children. Uh, because the ventricular spaces, the CSF spaces are very lesser in children. But the only thing is in vancomycin, sometimes in meningitis, the ventricular space or the ventricle size is normal. Sometimes it is higher. So drugs like vancomycin require higher doses if the ventricular size is enlarged due to the infection or due to inflammation. But if the ventricles are still normal, then the vancomycin dose is actually lesser. It needs lesser doses. So yes, it does depend on the size of the CSF uh, spaces or ventricle spaces. And this is followed
Okay.
by the volume of distribution. The volume of distribution, in fact, depends on the dose.
Okay.
And the volume of distribution also depends on the CSF clearance rate. Yeah,
Great. Yeah,
rate
exactly.
and the production. It does depend on the CSF production and the clearance rate.
Okay.
Let it
Even depends upon molecular weight, right, ma'am?
Yes, yes. If the CSF is produced in large numbers, then the volume of distribution will also be high. Therefore, the clearance will be high. So, because
Yeah,
you're going to ultimately drain the CSF.
exactly. Clear, clear. And one last question, ma'am. Like you mentioned, when you are dealing with antimicrobials with less protein binding, need less dose, and followed by if your antimicrobial is having high protein binding, we need to adjust it to a high dose. This is like a concept for all the antibiotics, or is there any exception, ma'am?
Um,
Like for
Again,
example, meropenem.
the antibiotic, I mean, if there is high protein binding, that means
Yeah,
there won't be free drug that will be there to get distributed. So you
exactly.
might need more dose for this, the antibiotics that have high protein binding, but also because ceftriaxone, vancomycin, or teicoplanin have high protein binding, and inflammation in the brain will allow the passage of the antibiotics through this. But again, these also have high protein binding, so that you need to give more doses of these drugs so that the more the dose, it will suffice to the high protein binding. There will be more free drug that is being available that will enter the brain through the inflamed meninges.
Yeah.
Got my point?
But if it is something intraventricular route, then
Huh.
these
So,
concepts won't be
yes.
like
So if it
feasible,
is
right, ma'am?
intraventricular route, then these concepts are not applied. The concept over
Yeah,
here is all about the drainage of the CSF as well as the drug clearance from the CSF.
clear, clear, clear.
So
Yeah,
when the
wonderful.
drug is getting directly going into the ventricles, and there is no, that's what it is, bypassing all the barriers of systemic circulation. No, so there won't be any protein binding, there won't be any absorption, there won't be any molecular size uh, uh, aspects that are being usually there when you're giving with the IV. So it's directly going into the brain. The only thing you have to remember is that with the intraventricular therapy, the clearance of the drug, the clearance of the CSF, the drainage of the CSF, and the clamp type. These four things
Okay,
you need to remember with the intraventricular therapy.
understood, understood. Very clear, ma'am. Thank you so much for clearing all the queries.
Thank you, Satya.
Once
I
again,
hope
thank you
you
so
have.
much for giving a insightful and informative session on something unique subject like intraventricular and intralumbar. Thank you so much, ma'am.
Thank you. Thank you so much. And Happy New Year.
Wish you the same. Wish you the same. And all the participants are requested, like if there are any queries, you can mail directly to the FCPI official mail so that your queries would be answered then and there. Thank you so much for watching.